Good afternoon, everyone, and a very good morning to some of our participants. Welcome to the afternoon session of ASPA 2021 on the second day, the vascular access track. I am Dr. Satish. I'll be one of the co-moderators. I'm a consultant in pediatric anesthesia and KK Women's and Children's Hospital. I would like to introduce my co-moderator, Professor Kim. Can I have Professor Kim on screen?
Hi, hello.
Hello. So many of you will be knowing Professor Kim. He recently spoke in ASPA Flex in the vascular access track and to the well-received talk on arterial access in pediatric patients. So Professor Kim is he's a professor in Seoul National University and also chief of pediatric division over there. He has over 260 peer-reviewed journals, many of them pertaining to vascular access. Thank you, Professor, for being a co-moderator here. So in today's world, actually, in pediatric anesthesia, vascular access is required well over and beyond what we use in theater. It may be in children in extremis, either in children's emergency or in wards, where we may need to insert an intraosseous access. It may be in a neonate where all peripheral access has been exhausted and we need to insert a central line. We may get requests from surgeons or from wards that we need vascular access, that they need vascular access for a week or two. And we are even delving into the realms which previously radiologists and surgeons used to occupy, where the patients require long-term vascular access ranging from months to years. That's the reason we have assembled today's speakers from all over the world to speak on topics. So we have 4 talks today. The first will be by Dr. Vibha Nayak, who will be talking about long-term vascular access in pediatric oncology patients. Next, we have the talk by Dr. Syed from UK. He'll be talking on midline catheters in sick children. Our third talk will be by Dr. Christian, who will be talking about brachiocephalic vein access as first choice in neonates. And last but not the least, the talk by Dr. Ji Nong from Singapore will be talking about intraosseous access in pediatric patients. I'll be going through the house rules. Can I have the house rules slides? So if you go to the live discussion tab and then press that, you'll be coming to the live discussion where you have the chat, questions, and the polls. You can type your questions in the question section. We have 2 poll questions by Dr. Vibha, and the results will be displayed at the end, and we'll be discussing at the end. Any technical delays, you can ask our technical team. Without much ado, I'll be introducing our first speaker, Dr. Vibhavari Milind Nayak. She'll be talking about long-term vascular access techniques and services in pediatric oncology. Dr. Vibha, many of you must have already heard her in the ASPA Flex lectures. She's a senior consultant and intensivist in the Basavattarakam Indo-American Cancer Institute for the last 10 years. After finishing her training, she pursued her interest in pediatric anesthesiology. She's worked as a treasurer and a newsletter editor in Indian Association of Pediatric Anesthesiology, where she's also been awarded an honorary fellow. Her interests include pediatric oncology, advanced vascular access and training, and she's been very active in training in various bodies, including AHA, ASPA, IAPA, PPLS, and WFSA. I'd kindly like to ask Dr. Vibha to take the stage.
Hi, a very good morning, afternoon, or evening, depending on the time zone that you are in. It is indeed my pleasure to be here today, and I thank the organizers for inviting me. I work in a tertiary cancer care hospital in Hyderabad, India, and I'm happy to share our experiences with long-term vascular access in pediatric oncology. Before we begin, I need to ask you, do you need to take care of children with long-term vascular access? Please select one option that best suits your clinical practice. Yes, frequently. Yes, sometimes. No, rarely. I also need to ask you, in your hospital, who performs long-term vascular access device placement? Anesthesiologists, surgeons, radiologists, nurses, or someone else other than the above? Okay, with such varied responses, I'm going to start with basics and also cover some practice relevant points that I'm hoping that you all will find useful. Let's begin with what is long-term vascular access. When vascular access is required for treatments lasting for longer durations, say weeks or months, very common in oncology, we require special devices called as long-term vascular access devices. And for today's session, I'm going to cover three of them: the implanted ports, the Hickman catheter, and the peripherally inserted central catheters. Now, how do we go about selecting the appropriate device for the patient? There are some differences between these three long-term vascular access devices, and our decision is going to be based on the duration of treatment that is required and the type of treatment that is given. Peripherally inserted central catheters are suitable when the treatment is for relatively shorter duration, like a couple of weeks, and also when the treatment is continuous. Between Hickman catheter and implanted port can be kept for few months to few years, and hence implanted port is preferred for patients requiring prolonged treatments. But also important point is that if the patient is going to require continuous treatments as required in hematological malignancies, Hickman catheter is preferred, particularly because plasmapheresis may also be required in these patients. But in those with solid tumors, where treatment required is intermittent but may go on for months or years, implanted port is the preferred device. The most commonly used gadgets for placement of long-term vascular access devices are the ultrasound machine with high frequency probes, and particularly the hockey stick probe is very useful for smaller kids. Though a device such as Sherlock 3CG, which uses electromagnetic navigation, is very helpful for guiding these catheters into the correct central line tip position. This device is not licensed for use in India, and we have to rely on intraprocedural fluoroscopy to make sure that the catheter is appropriately placed. There are various techniques that can help us reduce the radiation exposure to these children, like ECG guided tip adjustment, or even use of echo with bubble test to locate the tip placement in the SVC-RA junction. But there are limitations for these techniques, and intraprocedural fluoroscopy remains a gold standard. Let's begin with implanted port. Here is an explanted port which shows a port body, a catheter, and a connector that connects the two. Special needles are required to access the ports. These needles have a Huber tip which puncture the silicon septum of the port. The sizes that are available for pediatric use are 4 French, which can be used in infants, 5 French we would use in children up to 8 years, and 7 or 8 French is used in older children. I have a video for you depicting the implanted port placement technique. This is an 8-month-old child, and the internal jugular vein was accessed using an ultrasound guided puncture, which was followed by a modified Seldinger technique to place the catheter in the internal jugular vein. Port pocket is usually selected on the anterior part of the chest, and a combination of blunt and sharp dissection is used to create the port pocket. This is followed by railroading the catheter over a tunneler into the port pocket. Fluoroscopy is used to check both the loop as well as correct tip placement. And then the catheter is trimmed and connected to the body. Port is then placed in the port pocket and a final fluoroscopy image is taken before the wound is closed in layers. This is how the port would look after the wound heals, and a post-procedural chest X-ray is always done for documentation. We need to remember that in younger kids, there can be kinking of port catheters even with body movements, and this has to be counseled to the patient's parents. We also need to be aware of the technique used for accessing the port. In this patient, the port looks very obvious, but may not be in all the patients. But this is how you would hold the port. Use the Huber needle to puncture the silicone septum. And the most important step here is to be able to visualize a backflow of blood on aspiration. If the blood does not come back, please do not use this port and send it to the placement team for troubleshooting. Also, the technique of flushing ports is the push-stop turbulent method. After the needle is placed, the port is secured by using a support under the wings of the port, and then a transparent sterile dressing is placed over it. Moving on to Hickman catheter, which is a cuffed tunneled catheter placed in one of the large veins, either the subclavian or the internal jugular vein, and the catheter is tunneled out through the anterior part of the chest. The sizes that are available for use are 4 French single lumen, that is Brovier catheter in infants, 7 French double lumen catheter we use in children between 1 to 5 years, and 9 French double lumen catheter is used in children between 5 to 12 years. In children more than 12 years, we use the adult Hickman catheter, which is 12 French. Here is the video of the technique of Hickman catheter placement. The ultrasound guided puncture is very similar to the one that I have described earlier. The next step is to create a tunneling path and use a tunneler to guide the catheter, which is stitched to the tunneler and then passed through the tunnel to the puncture point in the internal jugular vein. Here you can see the Dacron cuff being positioned in the tunnel about 4 to 5 centimeters away from the exit point. The next step is determining the catheter length, which is appropriately selected up to the manubrium sternum. Then the tearaway sheath is torn as the catheter is guided into the internal jugular vein. Fluoroscopy is used to assess both the loop as well as the tip correct placement. And then a sterile transparent dressing is placed over the catheter. A post-procedure chest X-ray is always done for documentation. And on the right side, you can see a single lumen Brovier catheter, which is explanted, and you can see the components of the catheter. Moving on to peripherally inserted central catheter. Here, the catheter is placed in one of the peripheral arm veins using ultrasound. So either the basilic vein or one of the 2 brachial veins is used for this puncture. The sizes used are 3 French in children of 1 to 8 years, and 4 French is preferable in children more than 8 years. Remember, the size of peripherally inserted central catheter should not be more than 33% of the vein size to reduce the complications associated with these lines. And At least a 3 French size is required for frequent blood draws in oncology, and hence our center does not prefer using these catheters in children less than 1 year. Here is a video on the placement technique of peripherally inserted central catheter. This is a 4-year-old, and you can see ultrasound imaging of the basilic vein being done and the needle placement, followed by passing the guide wire inside the basilic vein. A dilator sheath is put in, and then the peripherally inserted central catheter is put into the sheath. The sheath can be torn away or removed intact, particularly in these catheters. This is the Groshong catheter, where the catheter connector can be disconnected. And this gives the advantage of being able to trim the catheter if required based on the chest X-ray. Since this child had thrombocytopenia, this child received a padded dressing. A post-procedural chest X-ray is also done after these lines, and one needs to remember that the movement of hand is associated with significant displacement of the tip position, with the tip migrating inwards when the hand is by the side of the child. For most big catheters, we use the chlorhexidine impregnated dressings, which reduce the chances of bloodstream infections associated with these catheters. The success of long-term vascular access devices is based on teamwork. And in our hospital, the vascular access team consists of not just the anesthesia consultants with special interest in vascular access, but also the counselors, the operation theater technicians, vascular access clinic nurse, and the infection control nurses. And all these together, we are able to provide comprehensive vascular access services for our patients. Having a dedicated space for follow-ups is equally important. It's a place where you will be able to educate and counsel the parents, teach them dressing changes and flushing protocols. The training of vascular access should include various stakeholders. The vascular access team should receive continuing education based on case discussions. The trainee doctors should receive training in long-term vascular access device placement. There needs to be a scheduled training for maintenance, care, and troubleshooting for the nurses that take care of these children, also including when to refer back to vascular access team. And of course, I mentioned the patient or the parent counseling related to maintenance and care. As a team, we had to make maintenance protocols as well as paperwork for record keeping. We made access and de-access protocols, dressing protocols, flushing protocols, and also troubleshooting protocols. I'm going to discuss a couple of troubleshooting scenarios with you. The most common troubleshooting is required when the catheter is occluded. In this case, you can see a total occlusion of the catheter. And in this scenario, we can use an ultrasound visualization of both the catheter and the vein and assess whether the occlusion is intraluminal or is associated with a vein thrombus, which is absent in this patient. For intraluminal catheter occlusions due to blood clots, urokinase is used. A second dose can be repeated after 30 to 120 minutes, but the best results are obtained when it is allowed to dwell overnight. Rarely, one might require explanting the device if we are unable to remove the occlusion. Another troubleshooting scenario is catheter-related vein thrombosis. As you can see in this child, the internal jugular vein has a big thrombus, which can be identified on color Doppler as a filling defect. In these situations, we need to decide, do we need this catheter? If the answer is no, the answer is simple. We can go ahead and remove the catheter. But before we do so, it is important to start anticoagulation for 3 to 5 days before removal to avoid embolizing this thrombus. And this can be done by using unfractionated heparin or low molecular weight heparin in the dose of 0.5 to 0.75 milligrams per kg twice daily. This needs to be continued for at least 6 weeks to 3 months. If the catheter is precious and we need it, then anticoagulation can be started with monitoring of the thrombus. And we need to continue anticoagulation till the catheter is in place. Thrombolysis indicated only if the thrombus is limb-threatening. Some other complications that can occur in this group of patients are hematoma due to low platelet counts and infection due to low leukocyte counts. Rarely, there can be breaks in these devices, as can be seen in this video. For this type of PICC line, the catheter just needs to be pulled out a bit and the fragmented part is cut and the rest of the connector can be re-established. A very rare but dreadful complication is catheter pinch syndrome, which occurs if a subclavian vein access has been used for these devices. A simple dye test can show the leak, as can be seen in this image. It is important to remove these. Rarely, the catheter may just break and we need to take angiographic services to retrieve the broken catheter. Thus, to conclude, smiles on the faces of our patients speak miles of the comfort with these devices. And hence, it is very important for each one of us to have the knowledge of long-term vascular access devices. For the least, we need to know what the devices are, be able to access them, and flush them appropriately. We also need to acquire the placement skills and provide our expertise wherever required. But the most desirable is to be able to develop vascular access teams to be able to provide comprehensive care for long-term vascular access for our patients. Here are some of my write-ups that you could find useful for further reading. Thank you so much for patient listening, and I'll be happy to answer your questions. Thank you.
Thank you, Dr. Vibha, for your excellent talk. We have questions in our Q&A. So I think, shall we first go through our poll results?
Sure.
So the first question was, do you need to take care of children with long-term vascular access? So about 55% of them have said yes frequently, and about 35% have said yes sometimes, and about 10% no rarely. So I think from a previous talk, we have seen that most of the attendees are pediatric anesthetists. So I think many of them do frequently take care of vascular access devices. Yeah.
Exactly. And that's why this topic is very important, that they need to at least know how to take care of a child who has long-term vascular access.
And our second question was, in your hospital, who performs long-term vascular access device placements? So about 50% said surgeons, 29% said anesthesiologists, 14% said radiologists, 4% others, and 4% nurses.
Yeah. So I think most of the implanted ports in many hospitals are done by the surgeons. And I think most of the steps, like probably three-fourths of the steps, are very, very familiar to us as anesthesiologists. It's just creating the port pocket, which is a very, very simple technique which can be learned very easily. And I think there should be no inhibition if the anesthesiologists are already doing other long-term vascular access device implantation to go ahead and start doing implanted ports. Regarding nurses, I think most of them would do only the PICC lines, and that is a little popular in Europe and America. But I think in Asian countries, there are still very less number of places where these devices are placed by the nurses.
So I think in the same, let's take a question from the same vein from Dr. Olivia. So she says, thank you for your excellent presentation. Could you share how you started doing implanted ports? How did you train for it? And how should other anesthetists begin to learn this crucial skill?
Yeah, so I think there are two parts to this answer. The first part is that I work in an extremely busy unit, and my surgeons are very, very busy. So they probably did look at somebody who could shoulder the entire responsibility of being able to provide these services, not just the placement, but the maintenance, the follow-up, troubleshooting. A lot of these things we are able to do by forming a vascular access team. And second part to this question is, how did I learn the techniques? So if the surgical oncology fellow or the resident can learn it during his 3-year training, I used to scrub up with surgeons, and after a couple of them, they were comfortable that I was able to do it. So I think you just need to learn it like a surgeon would learn any other technique. There are, to my knowledge, there are no special courses where implanted ports are taught, though there are courses for peripherally inserted central lines in many institutions.
Professor Kim, in Korea, what's the practice? Do the surgeons implant, or is it the radiologists, or do anesthetists implant?
For long-term catheter, such as the Hickman catheter and implanted port, these procedures are usually performed by surgeon, but the PICs, regarding PICs, is sometimes usually performed by the anesthesiologist.
Okay. So there was a question about have you used Groshong catheter, and what are the advantages and disadvantages by Dr. Teddy?
Yeah, so Groshong catheters are valve tip catheters. So catheter can be an open-ended catheter or a valve tip catheter. And these catheters were typically made so that it could reduce the incidence of backflow of blood into the tip, which is the most common cause why a catheter could get blocked. But unfortunately, with more and more articles coming up, there does not seem to be a very distinct difference in the incidence of thrombosis or occlusions that are associated with Groshong catheters and the open-ended catheters. But the biggest problem that I feel we had was that the referrals to the vascular access team increased, because if the sister is unable to really draw it in a particular way, like the backflow, she would say, oh, the catheter is blocked. And the instructions in my hospital are that if any long-term vascular access device, there is no backflow, it has to be referred to the vascular access team so that we can troubleshoot, make sure it is in the right place before the chemotherapeutic drug is given.
Okay. So I think we'll take one more question. Maybe I'll just combine. So it's about, can you share the flushing protocols of different LVADs, and can antibiotic lock be used to prevent line-associated infection in LVADs?
Yeah, so I think flushing, since we are short of time, flushing protocols, I'm just going to be very quick with it because these protocols are available everywhere. The protocol depends on the device that is used. What is the dead space of each device? Like Hickman catheters, the tunnel catheters have a higher dead space as compared to PICC lines. So you need to give at least 1.5 times the dead space as you would want to use. So flushing actually includes just cleaning the catheter and locking it. So cleaning can be done with 10 to 20 ml of normal saline. If you've aspirated blood, if you've given blood or blood products, you definitely require 20 ml. After a drug, it can be 10 ml. For locking, as I said, it has to be at least 1.5 times the dead space of the device. There has been the old traditional way of doing it was to use heparin locks for locking the catheter. But in patients who are like oncology patients where platelet counts can be on the lower side, or you can expect the platelet counts to fall down, we use normal saline as locking solutions too. So for long-term vascular access devices in the hospital, in between usage, the lockage is done only with normal saline. But when the patients go home and they are on a long-term follow-up, like they would come for flushing, say for 1 month or even 3 months for implanted ports, that's what we call, we do use heparin locks for these type of patients. And the antibiotic lock, I think it can be used if the line is really precious. If the line is really precious and the patient does not have overt signs of sepsis, you can use antibiotic lock, but routine use of antibiotic as a lock solution is not recommended. And we have used it once or twice only when in neutropenic patients, we've got cultures positive through the line, and the line was precious. Anything that Dr. Kim would want to add, or Dr. Reddy?
I think we have covered as much as we could in the short period of time. Thank you, Dr. Bibha. So Professor Kim will go on to the next talk.
Yeah, thank you. Wonderful lecture. I think it was a great answer to various questions. Now, I'd like to introduce our second speaker, Dr. Shwedi Sanola from the UK. He is consultant pediatric anesthetist at the Elderly High Children's Hospital. His special interest is anesthesia for congenital heart disease and transesophageal echocardiography in congenital heart disease, and thoracic anesthesia in children and one-lung ventilation, and also, of course, long-term venous access in children. Without further ado, I want to hand over the microphone to the Dr. Said. Dr. Said, please.
Good afternoon, everyone. I thank the organizing committee of ASPA 2021 for giving me the opportunity to discuss about my experience with midline catheters in pediatrics. In the next 15 minutes, I would like to discuss what a midline is, what in my mind a midline is. I look at the background of use of midlines perioperatively, why I change in my practice. Look at some of the indications of midlines in a practice, and also what catheters we use as midlines. We'll also look at the initiative we have in our hospital, the NURSLET, Advanced Vascular Access Team, and a few salient features about ultrasound-guided midline insertions. So starting with the midline, in my mind, it's a peripheral vascular access device for which can come in varying lengths and varying diameters. We have the Y-gown catheters and the arrow catheters that are used as midlines. They come in 4 centimeters to 20 centimeters length and 24 gauge to 20 gauge diameters. These catheters or midlines are inserted via upper limb, the peripheral veins in upper limb or lower limb. The final position of the catheter tip is not in the central vein. This is a key point we need to remember about it. And that is recommended for any drugs of fluids which are compatible with peripheral administration. They can also bleed back, thus enable us to sample blood. Now, why I changed my practice, why I went on to using midlines more often, perioperatively. This is an incident which I've taken up from the clinical governance meeting a few years back. And I'm sure this is not a unique thing to a certain clinician or institution. I think we all come across these kind of situations where the cannulous tissue during the procedure or on the ward. And when this happens, it's very unfortunate for the child, and it's not a good quality of perioperative practice either. And so I've been thinking about it, and in my mind, the reason why it happens is that we're using ultrasound more often for cannulating veins which are deeper under the skin. And if a cannula, for example, a Gelco catheter, which we use often in our hospital, a 24 gauge Gelco cannula is about 19 millimeters in length, and a 22 gauge cannula is about 23 millimeters in length. When we're accessing deeper veins, the length of the catheter, which remains in the vein, is maybe about 5 millimeters or 8 millimeters. I think over time, with the fluid leaking from the puncture hole which is created in the vein, the distance the cannula has to traverse before it gets into the vein increases, and eventually, I think it tissues. And I think it happens more often when you're using volumetric pumps and infusions under pressure. So from that point of view, I've changed my practice of using longer catheters, which are basically midline catheters, or using longer cannulas. Some of the other cannulas we use called the Abracat cannulas, they have a longer length compared to the Gelcos. But I think using a midline catheter gives me a peace of mind and a confidence that what drugs I'm giving and medicines I'm giving are reliably going to the patient. That's how I changed my practice. So that is one of the indication I use it for, a secure venous access for perioperative use. I use it for intravenous antibiotics as well. And it's a common practice in a hospital for the patients needing intravenous antibiotics for 7 days or more than 7 days to have midline catheters. However, it is also important to remember what antibiotics we're using. Some of the antibiotics like vancomycin, ciprofloxacin are very irritant, and they have a higher incidence of thrombophlebitis in the veins. So in such situations, I would go for a PICC line instead of a midline catheter. Total parenteral nutrition. We have a peripheral formulation of total parenteral nutrition, which we give through midline, given that the tip of the catheter is not in the central vein. We use routinely midline catheters for children having cardiac medications like prostin and milrinone, and to an extent, the midline catheters are a routine thing for children, for right from babies, neonates needing prostin for detriment circulations. And in anticoagulation management, we use midline catheters often, but here we have two midline catheters, one for heparin infusion and the other for sampling. But it is used for heparin infusion. This is the guideline which we have in a hospital to guide the clinicians requesting for venous access. Midline catheters, as here it says up to 3 weeks of treatment, but in my practice, if they're needing for more than 10 days, I tend to resort to a PICC line instead of a long line. This is an example where the midline catheter is inserted in a neonate who came for a procedure in theater. As you notice, there's a PICC line, a midline, which has been inserted in the basilic vein. It's a 5 centimeter 22 gauge arrow catheter. The tip of it sits in the axillary vein just under the clavicle here. I use this for giving IV infusions, blood and clotting products, whereas I have the central line for giving infusions, the inotrope infusions and the sedative infusions. That way, I'm assured that the drugs which I'm giving are reaching to the patient, and there's no risk of cannulas tissuing or being worried about whether the fluids we're giving are reaching the patient or not. These are the two catheters which we use routinely in our practice, the Vigon catheters, which come, as I said, 4 centimeters, 20 centimeter lengths, and the arrow catheters. The arrow catheters too are for arterial lines. I think they are made of a better material, and they have a lesser incidence of kink at the place where the catheter meets the hub. So we have discussed with the hospital clinical governance team, and we have agreed that we can continue to use arrow catheters till we get a better alternative for venous catheters. So arrow catheters for venous access, provided we label them appropriately, as we label them as long lines, so that everybody's clear that these are venous access lines. And we secure them very well with chlorhexidine dressings to reduce incidence of infection and prolong the duration of their function. as much as possible. About a few years back, we had the emergency list being inundated with requests for vascular access, which our colleagues used to either do it in theater under anesthesia or sometimes do it on the wards under ultrasound guidance. There was the vascular access team in our hospital, which used to do blood collections from patients, putting peripheral venous access devices. We trained them to use ultrasound, and now they call themselves the advanced vascular access team, and they have a ultrasound machine of their own and a trolley with all the catheters, which they go to different places in the hospital and insert midline catheters and peripheral venous access using ultrasound. And this is their experience. As you see, they're doing a reasonably good job. The number of requests to the emergency list has certainly reduced since the vascular access team has started working. They get annoyed when we say the vascular access team. They are particular that we use the advanced vascular access team to refer them. Cephalic vein is something which I often use as my first port of call for inserting midline catheters. The reason is that the cephalic veins are well formed. They have a bone underneath, and they're quite stable compared to other veins. As you see, as the needle is going through the vein, it results in complete collapse of the vein, and there's a risk of the needle going into the beyond the posterior wall. And so I tend to control the pressure on the vein with the with the probe, and if necessary, in the places where the veins are very small, I use a tourniquet as well. This is a video of the basilic vein being cannulated. The basilic vein is another which I use very often for midline catheters and as well as for PICC lines. For PICC lines, I routinely use the basilic vein. I don't have very my success rate using a cephalic vein for a PICC line is not that much. So I use basilic veins, and I think that they have a straighter route into the axillary vein and leading into the heart. As you see, the veins here are quite mobile. They're very close to the arteries, and they're quite deep as well. So here I make sure the needle and the venous access cannula is well into the vein before I remove the needle and insert the guide wire for changing into a midline catheter. Now, since the vein and artery are very close to each other, once I have inserted the midline catheter, I make sure, confirm that it is a venous vessel, not an artery. I do that with doing a blood gas analysis of that of a sample from the midline catheter, or if I have a transducer open, then transducing it to see a venous trace. The color of blood is not a fail-safe way of saying whether it is a vein or the artery, given that I deal with cardiac patients often, and majority of times the saturations are in low 80s or 70s, and the arterial and venous blood look the same, and the pulsatility is not a fail-safe thing either. I was looking at some of the literature available, and I came across this systematic review looking at more than 20,000 midline catheters. Though it was a predominantly adult study with a few pediatric studies in it, the average dwell time was 16 days, which is very much what we experience as well. The key factor is that the infection rate is less, but midline catheters have a high failure rate and high risk of mechanical complications like dislodgement, thrombosis, phlebitis, and occlusion. When we consult the patients for a midline catheter, we always have a backup plan. Backup plan of usually a central line, depending on the duration of infusion, the vascular access is needed, or a PICC line. So we always have a backup plan when we are moving patients for vascular access, long-term venous access. So to summarize, looking at our past experience and service evaluations, we come to a conclusion that the midlines or long lines. Midlines or long lines are more likely to finish treatment when they're in the upper limb. The duration function depends on what it is being used for. The duration of function is lesser when you're using more irritant drugs or infusions like TPN um, or antibiotics like ciprofloxacin and vancomycin. In high-risk cases, I use it as a temporary option, as a bridging thing before they can have a more definitive venous access like a Broviac, because quite often the patients with direct cardiomyopathy, when they come in, when they're referred to, they come into the hospital for the first time, they're in a very bad state. They get started on medical treatment, diuretics, ACE inhibitors, and milrinone. And milrinone is what we need the venous access for. And midline catheters can be very well used for milrinone infusion. And after a couple of weeks, when the patients are in a better situation, then we put more definitive access. As they wait for a very long time, quite a long time, going on the transplant list and the transplant being available. Aspirating midlines is not a good thing. There is risk of thrombosis more often when we're aspirating midlines. So we try to minimize the need for aspirating midlines. The long lines in the community or the midlines work longer, which probably is an indication that the patients are less sicker and they're not being used that often. And as I said earlier, the midlines have a higher incidence of mechanical complications, and we're always vigilant in case any complications occur, or if the pressures in the infusion start going up, then we plan for as an alternative vascular access. So this is our experience with midlines. So if there are any questions or if any comments about our practice, any suggestions, you can always discuss it later. Thank you very much.
So thank you. Thank you for your comprehensive review of the midline catheter. And there are several questions from audience, and one of them is that you mentioned about the advanced nurse practitioner team for vascular access, right? Is there any risk of de-skilling doctor in vascular access? If the nurse perform the vascular access, like this in difficult case, and there is a opportunity to perform the vascular access, especially for the younger doctors and the intern. So what do you think about this question?
Yeah, good morning, everyone. Thank you for asking the questions and a very pleasant introduction, Professor Kim. Yeah, there is a issue. There is an issue here, unfortunately. I think it's more of an issue in the Western countries. That's what I think. But I can comment about our practice in our hospital. The Advanced Vascular Access team, it's a good initiative. It has certainly improved patient care in the sense that the patients don't have to wait longer to get their venous access through which they can have the treatment. Second, that has reduced the workload on the theaters. However, as you said, the de-skilling issues. The Advanced Vascular Access team, they have set timings. They start at 9, finish at 5. They're not available out of hours. They're not available during the weekend. So to be completely reliant on the Advanced Vascular Access team is not a good thing. And as doctors, vascular access in pediatrics is a very important skill. It's a life-saving skill. And I think we should encourage the doctors to try and maintain the skill. And it all depends on the senior doctors. I think we have to encourage our junior doctors to try and continue practicing insertion of vascular access in children. And with the advancement and introduction of ultrasound, and in fact, in our hospital, we have plenty of ultrasound machines to understand that even the nurses can carry one with them. So we should encourage the junior doctors to use ultrasound and try and maintain their vascular access skills and not be dependent on the nurses completely for this technique or this skill.
Thank you. So next question is about the diameter and length of midline catheter for a peculiar patient. Do you have any formula for determining the insertion depths for midline catheter, or do you have any formula to choice of the size of the midline catheter, depending on the patient age?
I don't have a formula, but from my previous experiences, I tend to use 24 gauge, 5 centimeter arrow catheters routinely for children who are neonates, say less than 3 kilograms or so. For older children or more than 3 kilograms, I tend to go for a 22 gauge arrow catheter. The length is variable. I usually stick to 5 centimeters, and that seems to do the job, because I use it more often perioperatively. A 5 centimeter arrow catheter, irrespective of the size of the child, should do the job for me. For children who are older than, say, bigger than 10 kilograms in weight, I tend to go for a 20 gauge catheter. But it's all with experience. I don't have any formulas to decide what to do, but it's just with experience.
Yeah, thank you. So maybe there is a discussion is from about because we concerned about when we insert the central venous catheter or the longer catheter like a PICC, the insertion depth is quite important, but the midline catheter is just the length of the midline catheter is not long to reach the SVC and RA junction. So in terms of midline catheter, the insertion depth is, I think, is not a big issue, right? Is it right?
I would agree with what you say, Professor Kim. But having said that, in some of the very small babies, say a kilogram or less than a kilogram, even a 5 centimeter midline catheter, which is placed in the basilic vein, might end up in the central vein, or more of an issue of going up into the neck. So in babies who are really small and I'm using the basilic vein, I tend to do an X-ray before I send them back to the ward to make sure it's not gone into the neck.
Yeah, so especially, yeah, so it's very good comment, especially with very small children, even if midline catheter, the insertion septum, it will be matter. So we should be careful when the insert, especially for very small children, right? Okay, thank you.
So I said, if it's in the central vein, do you pull it out?
No, I wouldn't pull it out. I would leave it in, provided it is not heading into the neck and it's heading in the right way. I'll still leave it in, but be aware of it.
So I think that we had better move on to the next speaker. Dr. Shahris, please.
Thank you, Dr. Sayed, for the excellent talk. So we'll move to our next speaker. Our next speaker is Assistant Professor Christian Breschen from Austria. So Dr. Breschen is a consultant pediatric anesthesia from 1993 in the General Hospital of Klagenfurt in Austria. He was the head of ASPA from 2009 to 2013. For those of you raising your eyebrows, he was the president of Austrian Society of Pediatric Anesthesia. He worked in Asia, that is, he worked in Singapore from 1998 to 1999, where he worked with many of our senior consultants. He's had many publications, and his co-authorship in 6 books. Many of you who have attended the vascular access talks in Europe would have heard his talks, and his clinical and research interest is in ultrasound-guided supraclavicular cannulation in brachiocephalic vein, which is his topic of talk today. Professor Breschen,
I will now talk about centrally catheters in neonates. Some of these patients are really small. Neonates are non-cooperative. That's why some kind of sedation is required in order to be able to place these catheters. In addition, they have a large occiput requiring hyperextension of the neck in order to have access to this region. They're also very prone to heat loss. That's why the placement of these central lines must be quick and the least invasive technique should be applied. Ultrasound guidance nowadays permits the insertion of relatively large bore centrally inserted central venous catheters in babies whose weight comes down to 350 grams in terms of the brachycephalic and 540 grams in terms of the indolent jugular vein. And these catheters can remain in place up to a period of 5 to 6 weeks, even if non-tunneled, and they enable blood sampling, monitoring, high flow infusions, and can thus probably contribute to a reduction of morbidity, mortality, and sometimes even improve the neurocognitive outcome. The indolent jugular vein is still the most popular central vein in this age group. It's large, easy to scan, however, it's mobile and collaptic. That's why we recommend a more significant hyperextension of the neck in order to indirectly immobilize the vein a little bit. In addition, we recommend a low approach and to sometimes initially transfix the vein because it will always collapse completely due to the approaching needle. This is an unit where we push the tip of the needle through the indolent jugular vein initially centrally and only aspirate the blood while slowly withdrawing the needle because, as you saw, the vein collapsed completely due to the approaching needle. And then we proceed as usual with the straight internal guide wire and the two French Weigon catheter. The subclavian vein, on the other hand, is non-collaptic. However, it is small and there's a very disturbing ultrasound shadow of the clavicula. The problem is that you do not see the advancement of the needle below the clavicle, which is a significant distance. And this, together with a small size, makes it all in all a very difficult access in my mind. The femoral vein is small, collaptic, mobile. Femoral venous catheters carry a high risk of infection and thrombosis. However, recently, Ostrop described the successful use of ultrasound-guided tunneled femoral venous catheters in a group of neonates. Anyway, due to all these problems, we actually turned to the in-plane cannulation of the brachycephalic vein via the supraclavicular region. This vein is non-collaptic, large, and there is no disturbing ultrasound shadow of the clavicle. And this is what we eventually aim at the long axis view of the brachycephalic, in this case, left brachycephalic vein. Of course, aortic arch, pleura are close by, but when you use the implant technique, you see what you're doing. Initially, we always look for the indolent jugular vein at the neck, then we tilt the probe behind the clavicula so that we can see as the indolent jugular vein runs into the long axis view of the brachycephalic vein. This is a 680-gram baby not too long ago. The size of the vein was 1.7 millimeters. We cannulated the vein with a 24-gauge cannula. You see as the cannula tip enters the vein, and when the tip is clearly inside the vein, we put the probe aside, railroad the cannula over the needle into the vein, make sure we can aspirate blood, and if you can do so with a fully inserted cannula, not much can go wrong anymore. Then we proceed with a straight internal guide wire, check the course of the guide wire, which is called tip navigation, remove the cannula, perform minor dilatation with a 22-gauge cannula, insert the two French Weigon catheter after cutting it to the appropriate length, and then we fix it with sutures, glue, and transparent dressing, as shown here. This is statistics of our brachycephalic vein cannulations in neonates weighing less than 3.5 kilograms over the first 12 years. It includes 585 babies. The weight comes down to 550 grams. and 26 babies weighing less than 1 kilogram had been included. The eventual success rate in this age group was 97%, the first attempt success at 75%, and meanwhile, we are slightly more successful when going for the right as compared to the left brachycephalic vein, something which used to be vice versa until a few years ago. And we had 3 inadvertent subclavian artery injuries and no other puncture complication as yet. Dwell time is around 2 weeks in this age group, and we had 2.2% long-term complications, including 5 infections, 1 thrombosis, and 8 catheter obstructions. All of these complications happened a long time ago before we introduced the bundles. When you take a look at the statistics of the internal jugular vein cannulations at our institute, it's quite similar. However, we virtually never use this approach anymore due to all the problems described with the internal jugular vein previously. Meanwhile, we are very familiar with the brachycephalic venous access, so we might use it as an alternative in a difficult peripheral access situation, as in this 2-kilogram baby coming for inguinal hemiotomy with no veins left. So the baby was just breathing sevoflurane spontaneously via mask while we cannulated the right brachycephalic vein. You see as the cannula tip enters the vein, when it's clearly inside, we proceed as usual, put the probe aside, railroad the cannula over the needle into the vein, make sure we can aspirate blood, insert the straight guide wire, check the course of the guide wire, and then we insert a 2 French vacuum catheter, which we just fix with transparent dressing. We do this in a semi-sterile fashion. The catheter will be taken out soon after surgery. Sometimes the cannula tip can abut the vessel wall, meaning that you cannot aspirate blood after full insertion of the cannula, and you can then, of course, not insert a guide wire. We've observed this problem only in babies weighing less than 1 kilogram. And in order to overcome this, you can either incompletely insert the cannula and then proceed with a guide wire insertion, or what we would still prefer is shown in this clip, 550 gram. We cannulated the right brachycephalic vein with a 24 gauge cannula. You see the cannula entering the vein. When the tip is clearly inside, we put the probe aside, railroad the cannula over the needle into the vein, couldn't aspirate blood as mentioned, so we withdraw the cannula until we can aspirate blood, and then we fully insert the cannula while injecting the aspirated blood. And when the cannula is fully inserted and you have the option to aspirate blood, then, as mentioned previously, not much can go wrong anymore. A more frequently observed problem is the fact that you insert the cannula, however, you can simply not recognize it on the screen because of an inadequate alignment of probe, vessel, and cannula. In this case, we recommend to move the cannula slightly in plane towards the clavicle until we can see it on the screen as shown in the right lower corner. This is something we did in this 2-kilogram baby by moving the cannula slightly towards the clavicle, a movement which is so minimal so that you can't recognize it with a clear eye. You could nicely see the cannula entering the vein when it was clearly inside, the tip clearly inside. We put the probe aside as usual, railroad the cannula over the needle into the vein, and make sure we can aspirate blood. There's a nearly occluded left brachycephalic vein due to fibroblastic sleeves caused by a previous catheter, meaning you have to pre-scan the veins before going for them in order to make a good choice, in order to determine the patency. The left brachycephalic vein runs nearly horizontally, making it usually easier to scan and cannulate, whereas the right one takes a steep caudate direction making it usually more difficult to scan and cannulate. And sometimes you're able to only obtain a circular appearance, in this case of the right brachiocephalic vein, meaning that you can only see the initial part, and then this implant technique is going to be very difficult. So just by the sonographic appearance of the vein, we can already tell a lot about the ease of its cannulation. This is our Sonosite device with a 13 megahertz linear bulky probe. There may be other options meanwhile with smaller probes, higher frequencies. However, always make sure that you avoid an insertion angle of more than 30 degrees, because then you will not recognize the cannula on the screen anymore. These are our cannulas we use when going for the brachiocephalic vein, 24 and 22 gauge. And in case of the interjugular vein, where the technique is a completely different one, we use this 22 gauge needle with an attached 2 ml syringe. Always use a straight internal guide in this age group, and this is one of our Weigon catheters, in this case 2 French 4 centimeters. Meanwhile, there are a few studies which have shown that ultrasound-guided brachiocephalic vein cannulations have been associated with a high puncture success and a low puncture complication rate in infants. And there are some indications that brachiocephalic vein catheters seem to have fewer long-term complications as compared to interjugular, femoral, and even epicutanic cable catheters in terms of fewer obstructions, infections, and thrombosis. The guidelines, the so-called bundles, as introduced by the various vascular access societies, recommend sterility, skin disinfection with 2% chlorhexidine, something we haven't got, so we have to use isocit instead. Pre-scan the vein, which is called rapid central vein assessment, measure the size, because the outer diameter of the catheter should not exceed 1/3 of the vessel lumen in order to reduce the risk of thrombosis. Use ultrasound for the cannulation. Check the course of the guide wire, which is called tip navigation, and check the correct catheter tip position in the cable AJ junction by echocardiography or intercavitary ECG. Unfortunately, we haven't got an echo probe, so we have to use an ordinary adult COMEX probe. With this, however, we can see the superior vena cava very nicely from the subcostal view. And when you check saline, and when you see the bubbles appearing immediately afterwards in the right atrium, as shown here, you can be sure that the tip of the catheter is in the correct position, which means in the lower third of the superior vena cava. The estimated catheter length in terms of the left brachiocephalic vein is body length by 10 centimeters, and for the right, body length by 10 - 1. I have to say, though, that these formulas are non-evidence-based at all. It's meanwhile accepted to cut the catheter tips of single lumen catheters to the appropriate length. In the middle, you actually see the tip of the cut catheter under the microscope. In my mind, it looks cleaner one than the 2 other original ones. In addition, the guidelines recommend the use of cyanoacrylate glue in order to seal the exit site. Use sutureless devices. I have to say that we still suture our catheters when they're non-tunneled, and use citrate or rhodidine if you want to lock the catheters for a longer time. Summarizing, real-time ultrasound guidance is mandatory for the placement of all central venous catheters in neonates. The only exception are the epicutanic cable catheters, which, however, are very small bore and can't be used for any blood aspiration or high flow infusions. Surgical cut-down techniques are meanwhile completely obsolete due to the high long-term complication rate. And we think, and this is also the recommendation of all vascular access societies, that the first choice in children, particularly in neonates, should be the implant cannulation of the ultrasound guide of the ultrasound guided implant cannulation of the brachycephalic vein via the supraclavicular region. This vein is non-collaptic, large. It's usually easier for the left side. Pre-scan the vein, and I think all in all, it's a very safe approach after adequate training. Of course, sometimes the canal tip comes very close to important structures, as in this 1 kilogram baby, where the canal tip came, as you see, very close to the aortic arch. But implant technique, you see what you're doing, you know exactly where you are, and thus I think it's all in all a very safe and appropriate method. I thank you very much for your attention.
Another excellent talk. Professor Christian, we have a few questions in our Q&A.
All right.
Just go through a few of them. So one of the questions, can I ask, is there any significant structure in the neck you could injure during cannulation procedure and which you could miss by ultrasound?
Yes, in this case, I'm thinking of the thoracic duct. The problem is you can't see the thoracic duct via ultrasound. Now, this is a more significant problem for the left side. However, if you really use the implant technique, you should not hit it because it comes slightly from behind. However, you also have to say that in around 6% of the population, there's a pendant to the thoracic duct on the right side. So saying that you always choose the right side because you want to avoid hitting it and maybe ending up with a hylothorax is not really correct, because these hylothoraces have also been described on the right side. Usually nothing will happen if you injure it, but of course you can have sort of bad luck and then you've got a hylothorax, and this requires, as you know, long-term treatment.
Thank you. So our next question is, you said the brachiocephalic vein is the first choice. How widespread is the knowledge and use of brachiocephalic vein?
I don't know how widespread it is. What I'm part of the Vascular Access societies like Gavesel, Vokova, and these sorts, and it's above Amaro Pichiruti. I'm sure you've heard about him, who is sort of the leading guy, and he doesn't even discuss about not using the brachiocephalic venous access as the first choice in children. What he, however, recommends is to go for the brachiocephalic vein, and in case of long-term catheters, proviacs, ports, etc., to channel the catheter to the infraclavicular region then. But initially, they always go for the brachiocephalic vein. How widespread it really is, yeah, I think it's pretty widespread in continental Europe, that's for sure. France, Italy, German-speaking community. Meanwhile, I'm not quite sure about the Anglo-American community.
So many of us have not done that. So they're asking, what is the learning curve? Means we are all familiar with interjugular. So for those who are familiar with interjugular, what's the learning curve?
Yeah, well, I've been asked this question many times, and then I said the number, yeah, 20 babies. But I mean, this is just a gut feeling. What I think you must really be familiar is with the zone anatomy. This must really be in your mind. You must know what you see. You must be sure it is a brachiocephalic vein, because the artery is immediately behind, so you can actually miss it. And secondly, you have to be familiar with the in-plane cannulation techniques. Now, this is something you can learn in regional anesthesia. You can learn it on phantoms. And if you combine the knowledge of the zone anatomy and being familiar with the in-plane cannulation techniques, then I think it's pretty straightforward.
Okay. And
there's a steep learning curve then in my mind.
Yeah. So where do you insert the brachiocephalic vein? Is it always in theater, or do we do it in the ICU or other locations too?
Well, we insert most of them in the operating room because most of our babies are surgical ones. However, sometimes the neonatologists ask us for a line in the NICU, and then we go to the NICU. We do it in a sterile way there. We, however, in the very small babies, I have to say that we always intubate them if we insert the catheters. In the NICU, if they're just in the operating room and if they can't breathe on their own, we would do this just with inhalation of sevoflurane. But this is just true of the operating room. In the NICU, we would actually intubate them. But these are then also usually very sick babies, and many of them are already intubated anyway.
Professor Kim, would you like to pick any question, or would you like to ask anything before we close this Q&A?
Are you familiar with the brachiocephalic venous access? Is it widespread in the South Asian region?
At least in Singapore, we don't do it. We go for internal jugular, or next line will be femoral. But yeah, we done it a few times, but not many. Yeah, Professor
In
Kim.
In South Korea, is that it depends on institution. In our institution, we usually sometimes perform the brachiocephalic vein, especially in small baby in the operating rooms. But our first choice is the internal jugular vein.
All right.
You talked about cutting the catheter. What length do you cut it at?
Yeah, well, I mean, I showed the formula. It's if it's non-channeled, I have to say, then it's body length by 10 for the left and body length by 10 minus 1 for the right. But I have to say that this is a non-evidence-based formula. The formula is actually more complicated, but this formula is very easy to keep in your mind. And above all, in emergency or urgent situations, for instance, in the middle of the night, you do not really have to think very much about the length otherwise. So it's very easy. And in my mind, these are good formulas, but they are not evidence-based. But they are very easy to keep in your mind. You can use it easily at any time. That's why we're using it, and I think they're quite good. My personal opinion, I have to say, just my personal opinion.
Thank you, Dr. Brescian. Professor Kim, if you'd like to close and introduce our next speaker.
Thank you very much.
Okay, thank you for your excellent lecture. I would like to introduce our last speaker, Dr. Jin Ong. He is a senior consultant of emergency medicine, KK Women and Children Hospital. And he is the International ICOR Pediatric Life Support member, and he is also a Singapore Research Station and First Aid Council Pediatric Subcommittee Chairperson. Today, he will talk about intraosseous access in pediatric patients. Dr. Jin Ong, please.
Thank you, Prof. Kim, for the kind introduction. So I will talk about pediatric intraosseous access. This is quite well known in the emergency departments, but perhaps maybe not so much in the operating theaters, as well as perhaps in the intensive care where other lines are available as well. First of all, I would like to declare that there's no conflict of interest. I'm not promoting any mechanized intraosseous device, nor do I own any shares for any of these devices. And I tried to be as comprehensive to show the pros and cons of each of these devices, just to share there are limitations as well. First, we'll go through the indications, the contraindications, the procedure itself, how we stabilize, and the complications as in any procedure, right? The thing about intraosseous is how much time do you have, and if you have, as mentioned before, time to get the brachiocephalic vein, or if you have time to do all this, it is actually preferable to do those. However, if you need it in critically ill children, it is advised that within 90 seconds or 2 to 3 attempts, whichever is longer, that you should get some form of vascular access, then intraosseous may be an alternative. So this has been what ILCOR and AHA as well as ATLS have recommended, that for all ages, especially during cardiopulmonary arrest, when no vascular access is present, and basically time is brain and heart, that you use it as an possible access if you can't get intravenous readily. This includes newborns if umbilical and peripheral venous access are delayed or unsuccessful. So the IORA is preferred over endotracheal drug administration of epinephrine, for example, during cardiopulmonary resuscitation. There has been a systematic review done in 2019, which shows that there is evidence for use even in neonates. But there is, of course, technical difficulties, and I'll go through them in this lecture, right? So as you can see, for intraosseous access, what you're going into is the bone marrow. Where you want to go is just below the growth plate, where it's a bit more spongy and there's more space for your needles to go in and provide the life-resuscitating or life-saving drugs that you need to give. As you go more distal into diaphysis, which means in the middle of the bone, the space is much less and resistance will be higher and likely complications will be higher. The problem is the growth plate, where you do not want to destroy the growth plate as it can cause potential limb length discrepancy in a young child, right? That's where the little tips are. Just to go through quickly, in terms of contraindications when there are fractures, basically remember what you're doing is to put a needle into the bone marrow, and if there's another fracture, it will extravasate from the other side. So if there's overlying skin infection, this is relative as well, because then you introduce bacteria and result in osteomyelitis, which is extremely difficult. But in the context of a patient who is critically unwell or in cardiopulmonary arrest, the pros and cons needs to be weighed. Underlying metabolic bone diseases such as osteogenesis imperfecta, but having said that, there have been cases using mechanized IO which has shown success as well. So these are relative. If this is a life-saving procedure, then the pros and cons need to be weighed. If there are vascular access available, this is relative, then intraosseous may not be the way to go. And of course, the complications of which would be compartment syndrome due to the ischemia, especially if you instill vasoreactive agents, and that will result in skin soft tissue necrosis, in a worst case scenario, limb ischemia as well. So any infections as in any lines, but instead of the veins, you have osteomyelitis. When you drill, and if it's inappropriate technique, sometimes you can slough the skin due to the spinning drill. That can occur. Fractures as well, especially in the abnormal bone, and growth plate injury. So there are reports of, and there's a theoretical issue with fat embolism, but this is more theoretical risk. And there have been some studies that showed that this is not significant either ways. Although extended use beyond the resuscitation period has been reported, we tend to prefer that they are indicated for short-term use until the other techniques that we have seen today are instituted. This is because there are issues with intraosseous access, and the risk of complication increases with the duration of use as well. So we generally recommend that they should be removed post-stabilization, and as soon as you get other more secure vascular access, the intraosseous access should be removed. So this is just to give you a visual representation of what really happens when you put it into the bone marrow. Any drug that you instill can be given through intraosseous access. Again, especially in growing children where the bone marrow is highly vascular, any drug is actually can be given systemically via the intraosseous route as well. Just to note, the bone marrow aspirates and the blood that can be used for point of care or formal laboratory investigation, and we have done this in our real life as well. So, but we do recommend that you aspirate after the first 2 meals, especially if you're sending it for whole and cross match and correlations with the biochemistry. Discard the first 2 meals first. Again, if you don't have time, then the major issue is to use it for immediate resuscitation, and the bloods can be taken later. But do note, you need to label this blood because there may be marrow particles in it, and it may clog up the machine. So the laboratory needs to know they have to centrifuge the blood for all this. There is the manual intraosseous access, and those who have are familiar with this, if they have done pediatrics and have gone through an oncology unit, basically we tend to use the GFCD as well as the Cook's IO as you would in the bone marrow aspiration for intraosseous access as well. The gauge are relative and the sizes depend on the age of the patient. The gauge, the bigger the big gauge in a resuscitation context will be better. Remember, the bone is not the limitation, it's the depth of the insertion that is the limitation. There has been a mechanized device, and I'll divide that into spring-driven as well as drills. So in spring-driven, as you can see, it is a bit scary, as you note. So it's very forceful, and the impact can potentially, in a soft or fragile bone, cause mechanical fracture as well. Mechanized drills tend to be preferred, and I'm not saying this because of any conflict of interest, but it is more controlled, where the drill and the depth can be actually more nuanced, and with training, you know when when you're in the bone marrow. So which to use? If you're familiar with it, you're trained, and I would say that depends on what you have as well. Both are just as good if you're able to do so, but do remember that beyond, I would say 5 to 8 years old, getting a bone marrow into the proximal TB is extremely challenging because of the thicker cortex, especially in the adolescents as well. Prior to the mechanized drills that we have for intraosseous, it took me almost 15 minutes just to get into a 15-year-old cerebral palsy patient. So the presence of mechanized drills are a blessing in the emergency department, right? Just to show you how gentle drills can be. So even in the egg, if you drill it with very controlled and precise force, it's a very gentle thing. You won't even break an egg. And this is what can be found. And you can even put multiple IOs without breaking the egg, which shows how controlled it is. Do remember that this is quite different from a mechanical, unless you're really steady and good hands, which we tend not to have. And with spring devices, you will inevitably crack some aspects of the eggshell if you do it. So just to show the difference in the force and depth of insertion for these devices, right? So we look at the different comparisons, and I looked at this article published in 2015. Specifically, it's for anesthetists, and they use novice operators as well to compare with both adults and children the use of intraosseous manual versus drill. Again, in adult bone, the greatest difference is there, but across all ages, they found success and speed of insertion to be superior with the mechanized. Okay, so the other thing is that in the emergency department where I work, are there potential issues when you compare manual? But remember that it is about training, because if you work in a pediatric emergency department and not everyone is trained, and if you're familiar with using a manual, the success rate tends to be higher. So they found that in smaller kids, especially those less than 8 kgs, the rate of success is not so high in a setting of emergency department where majority of them are pediatricians. Again, it's all about training. Pediatric trained specialists may be familiar due to their prior exposure, but as mentioned, there are limitations in a bigger child as well. Whether it's painful or not, you can find this on YouTube where doctors drew their own leg, and it's been done. It's not as painful as what we think if you use a mechanized drill. Okay, it's not as scary as what we think. And in our pre-hospital EMS system, we do teach them, especially in the context of cardiac arrest as well, where intravascular, especially in a moving ambulance, is extremely challenging. The sites of insertion, basically, you would prefer it to be the proximal tibia. Alternative is the distal tibia. In older children and adolescents, you can use proximal humerus as per adults. Location-wise, basically where you want to go is to avoid the growth plate. So you use the tibial tuberosity about 1 finger breadth, medial, and distal to it. This gives you a nice flat surface for you to go as well. Alternatively, you can go at the mid-condyle area in the distal femur as an alternative site, right? So this is the preferred one, preferred intraosseous landmark for majority of patients. And it is very nice because it's a flat surface and success rates tend to be better here. So this is what happens when you insert it. Proximal tibia, basically you need to make sure the hands are internally rotated. It's a bit more difficult because you need to feel the greater tuberosity. So this one needs a bit of training as well. And this is, a lot of pediatricians are not very familiar with this route. Although there are some studies that show that the flow rate is higher in the proximal humerus compared to the proximal tibia. So in terms of gauge, remember this is the needle length, and this is what one of the mechanized drills suggests, that this is what you use. We tend to use the pink one, 15 mm in all children. And if you're using the proximal humerus, you might want to consider the blue, or if necessary, the yellow one. What you need to do is to ensure that when you insert it, make sure you don't start the drill first, puncture it through the skin all the way when you touch the bone. And then basically the first marking that you see should always be visible at the 5 mm mark, right? So whatever the size, the depth, it needs to be ensured that you can actually push it into the cortex. This is the same for the manual. And positioning, the force is that, remember, if the easy does it, you put a very gentle pressure, don't overshoot it, because it's a very controlled measure as well. And as the manufacturers say, allow the driver to do the work. You don't push it in, you don't have to. The driver will push it in, you just control when you feel the give. Just to quickly show you, on a live patient, in itself is no more than an IV. But do remember, the infusion of fluids is extremely painful, and this is analogous to bone pain. So it's actually the infusion of fluids that is painful and not the insertion per se. So in conscious patient, this is what has been advocated. Again, the results are variable even in adults, but in the context of time-critical interventions, you have to think about in critically ill patients whether you want to leave it to lock for 1 to 2 minutes before you insert it. The offset is that the pain, but in our context, in the emergency department, these are life-saving measures as well, right? So placement of, where you confirm is when you get bone aspirate, and then you can flush it, and you may contain aspirates. Stability of needle, but remember, it can be true and true. And the last thing is that, of course, you observe for swelling and regular monitoring. And of course, you look at for hemodynamic effects of the drug you're giving. If you don't see it, probably it's not in, okay? So these are bad examples of what not to do. These are bad placements where it's not even in, where it's in the intraosseous space or it's in the joint. So complications are extremely rare, but it has been reported in neonates and pram babies, especially, and of course, due to improper insertion and removal, you might get bent or dislodged intraosseous needles with very poor, with bad consequences. Just to note quickly that you can even use ultrasound to confirm, especially in the young infants, because the cortex is semi-radiolucent, ultrasound lucent. You can see, if you can see using Doppler flow, that there is movement only in the bone marrow, that confirms your placement, as opposed to you don't only see it outside when you do a flush. That means that you're not in the cortex yet. You're not past the cortex yet. And the advantage of this is that when you are in, but there's actually leakage around the needle, you can see some disturbance around the area. So this one may have problems later on. Okay, stabilization, there are ways of stabilization, and most of the commercial devices have ways of doing this. And this is a quick summary of the technique, basically as what we've mentioned. Put it at 90 degrees, not at 60 degrees, and enter it until you feel a give, then secure it as needed. The main thing is to observe regularly for complications. How to remove? Use a lower lock and then insert it and then pull it out. Never just pull it out using with your bare hands, because it's less controlled and may result in breakage or bending, right? Okay, so any questions, I'll be happy to answer.
So thank you for your excellent presentation. There are several questions from audience. The first question is about the age of patient. can we use the intraosseous route for the preterm baby?
Technically, yes. Again, it depends on the training. This has been reported even in the neonates, but I would say that the risk of, because of how the bones are, the risk is extremely high, especially if they're less than 1 kg, I would assume. And there have been some issues as well. If you do want to use in prem babies, I would seriously suggest that you use mechanized drill systems. The idea of this using mechanized is very well controlled. You don't need to apply a lot of force. You can do it in a very gentle way and then insert it. And even if you don't reach past the cortex, you can continue to drill if you're not there. So it's a very controlled manner.
Mm-hmm. Thank you. So how about the rapid transfusion? For the rapid transfusion, is it better in IOSS than the 24 gauge of small size IV catheter? Is it better?
I would say that technically a small size catheter especially is very far away from your central veins. It's the IO may serve as an alternative. It's actually easier because of the needle size. They tend to be larger bored. So I would say that however, placement wise, because of its limitations, you might extravasate or cause a bigger hole. Intravenous is still recommended, but anything you can get, and we have done this on our patients in cardiac arrest as well. We don't find any issues when you give hand push, adrenaline, vasoactive drugs, phenytoin, phenobarb, or otherwise using intraosseous.
Mm-hmm. Mm-hmm. Any drug that cannot be delivered through the intraosseous route then?
So all drugs that you can deliver intravenously can be given through the intraosseous route because as you can see, it goes into the vein. It's pretty much like I would say a midline catheter where it goes into bigger rather than peripheral veins into the if you go into the proximal tibia, it goes into the posterior veins in the popliteal fossa. As you note, and if you go into the proximal humerus, it goes directly into axillary vein as well.
Okay. So during the cardiopulmonary research station, you showed the several sites for the intraosseous route. Which site is your preferred site for during the cardiopulmonary bypass is a quite complex situation, and
Right.
the compression is
Yes, so the more peripheral it is, we tend to find a bit better, and the familiarity in terms of training as well. For our paramedics, what we have done, even for children, we have advocated that they use the proximal tibia. Why? Because the flat surface, anyone has done drilling before, if the surface is flat, it tends to be higher success rather than slippage. So it's easy, and you go 90 degrees straight down to get past the cortex into the medulla. I would say that the flow rate theoretically is highest in the humerus, but technical issues in someone who's collapsed time is brain and heart. So you want a greater success and familiarity. So training is part of that. So we would say that if you can get access and you're trained for humerus, go for it, especially in bigger children. If you're trained for proximal tibia, then go for it. But placement is much easier in the proximal tibia for pediatric patients who are pre-adolescents.
Yeah, thank you.
Also, since you're talking about training, and here most of us are anesthetists, what do you think? How should we train for this procedure?
Okay, so what we have done is that we have advanced life support courses. Even in KK, we call it our own APR Singapore version, and we use it. You do the training via chicken bones. So any expired intraosseous needles we train, and department-wise, you can do internal training as well, where you can insert it with the chicken bones. It's kind of fun. It's a bit of waste of chicken drumsticks, but it's very good in terms of experience and to visualize all this, especially in the small bones.
Mm-hmm.
And do you have any frequency in which you train your residents?
The good thing is that the advantage of being in emergency department is that there are real life cases. Number two is the fact that we do the training for this station in our life support courses. So we would recommend that internal training that needs to be accreditation system to it. and success rate as well. So this is depends on familiarity and but in general, in most life support courses for accreditation, there is a 2-year limit, but internal training needs to be done to ensure that the skill set is just like what the other speakers have mentioned, that skill training is important and maintenance is important. As to exact timing, and this is still quite unknown because it depends on your resource, whether you're using an easy IO, mechanized drills, or if you're using manual. So it's slightly different as well, how you approach it. And sometimes we do both just to ensure that the training is up to date.
Mm-hmm. So I think you mentioned during lecture. Could you briefly mention comment about the contraindication, how long the intraosseous route can be kept?
Okay, so technically, there have been some FDA approval for use beyond the 24 to 48 hours, especially in adults. But for pediatrics, we tend to find that the complication rates goes higher once it's beyond 24. I would say that once you can get a proper access, you should take the intraosseous out as soon as possible. This is part of resuscitation. I will put it in the same way as an LMA. If you can get in a CICO context, you use an LMA. If you can't get a venous access of any route, use intraosseous. But once you can get it, then you go for the venous, especially a central line. But this buys you important time to resuscitate the patient until you get a return of spontaneous circulation to get the other aspects in. I would put the idea of time is brain. You don't want to result in unnecessary prolonged downtime or hypoxic ischemic encephalopathy. So every second counts, and that's where the intraosseous comes.
Okay. So how about the osteogenesis imperfecta patient?
Right. So although it's a relative contraindication, but again, having a fracture in a sense of a minor fracture in the context of cardiac arrest, I think it's a relative contraindication. And there has been case reports where it's successful if you don't use it for a prolonged time, because there can be micro fractures, but that is fine. But if you're using, this is only in context of using mechanized drills with good control. That's what the eggs are for as a representation. So if you saw the video with the eggs, even if you do it in a very gentle manner, you don't apply unnecessary force, you can probably get good access.
Mm-hmm. Thank you. Dr. Satish, do you have any comment?
I think we'll have, if we can get all the speakers on, maybe I can ask the question in a similar vein. So Dr. Jean just said that his preferred access, if we say if a child comes to A&E, a 5 kg child who's in extremis, not in arrest, say, but looks like going to arrest soon, I think Dr. Jean will definitely say that he'll use the IO access if hands are cold. Yes, hands are cold and can't get anything. I would just like the view of all the other speakers. What would they go in and insert? Where will they look into first? You know, a 5 kg child, you've been called in extremis, hands are cold, can't see anything. So where will you go? Maybe we'll start with Dr. Syed.
Yeah, as you said there, Satish, if the child is in a peri-arrest situation and I have an ultrasound, which we have in our A&E department, and almost all the theaters and theater complexes have ultrasound machines in the hospital. So I would go for a ultrasound guided midline to just get the thing started, to start the resuscitation.
Okay.
And in my hands, it's as good as putting a cannula. It doesn't take longer than putting a cannula. Mm-hmm. With the ultrasound, of course, I have the advantage of seeing veins which can't be seen normally.
Professor Brescian, how about you?
Well, I think ultrasound is absolutely mandatory nowadays. There is no more excuse in my mind, definitely not for a central line. But as we have also heard, it's also very, very helpful for all the peripheral lines, brachycephalic, basilic, cephalic vein, saphenous vein, maybe to mention as well. Maybe we're a bit lazy, and that's why we go very straightforward for the brachycephalic vein. The babies are always asleep. We do not do this in awake children. And one of the reasons why we're also quite straightforward going for this vein is because thus we can train our junior guys in non-emergency situations. But of course, you have to be aware that it can cause significant complications with any kind of neckline. That's for sure.
Dr. Vibha, maybe a similar question, but if a child comes, say, with a port there, and child is an extremist, in A&E you don't have Huber needle. So what would you advise, or what would you do?
So a child with a sorry. So a child with a port, definitely
Yes.
the access is there. Even if Huber needle is not there, you can use a regular tip needle. The reason why Huber needle is advised is only because it increases the longevity of the septum. But in a situation where the child could die, I think using any needle that is available to puncture it, check the backflow, and then give adrenaline is what I would want to do.
And otherwise, what is your preferred? If you have
I think periaris scenario, peripheral veins, look for the dorsal veins or great saphenous vein. If you think that the veins are not available, intraosseous access is the next step. We have the bone marrow needles in our crash carts, and that is what we use.
And Professor Kim, in this situation, what would be your preferred go-to access?
So you mentioned what specific situation?
Yes, a 5 kg child, say in A&E, arms and legs are cold, you can't find a peripheral access.
I would like to prefer the peripheral, if I can answer the peripheral pain, and I prefer choice the peripheral access. But if the patient need the central venous access, I prefer the internal vein.
Internal jugular.
Yeah.
Right. I agree with everybody. Remember, the idea is that if you can do it within 90 seconds, whichever method, and that's what we do as well. So those with port, we actually have the needles ready. We don't need to size it because it's a life saving. So our role in the emergency department, sterility, we just 7 swipes and then just enter. This is our critically ill children. We'll take care of infection later on, but it's about life saving. So if you can, and that's where I want to put it to everyone, the audience as well, that if you can do whatever you can and train to do within 90 seconds, the downtime, then please do go ahead. But if you can't, that's where the intraosseous serves as a life-saving adjunct. Pretty much like your RMA, as mentioned in the CICO context. But if you do not throw away your current skills, if you're not familiar with intraosseous and then you go for it, and then you're actually better at the be it a midline catheter, ultrasound. We do use ultrasound as well. So our caveat is whatever method you use, central lines, if you can get it within 90 seconds, go ahead. If you can't, there comes the intraosseous.
Okay, so I think we are at the end of our session. I would like to thank all our speakers, Dr. Vibha, Dr. Syed, Dr. Breshen, and Dr. Jean Ong, and also my co-moderator, Professor Kim. We are almost ending our second day session, and we'll be having a survey at the end of this talk. So I would like to invite our speakers and all our audience to fill up the survey. Again, a big thank you for all our audience for being for asking questions during the session and being very active. And please continue with our next session, which is a very interesting session by faculty of ASPA. Thank you very much again, and have a good day.
Thank you.